And neuroretinitis is called that because there is infection or inflammation, the itis, and we're going to see a star figure of exudate in the retina, and the optic nerve is swollen. So it's retinitis from the nerve. It's usually unilateral, but can be bilateral. So here we have the swollen optic nerve, and in this particular example, here's the fovea. Because there's fluid leaking out from this disc, it will appear in the macula, and the fluid in neuroretinitis contains exudate, and the exudate will make a star figure pattern because it is involving the Henle's outer plexiform layer. So when we see the combination of a swollen disc and a star figure of exudate, that should raise the suspicion that this is an infectious neuroretinitis. The most common infectious neuroretinitis that we see is cat scratch disease, which is caused by Bartonella, usually Bartonella henselae. And so we test that patient with IgM and IgG. As you know, the IgM goes up and then it goes down. The IgG lags behind, goes up and then goes down, but then becomes a memory B cell kind of stable level from memory B cell IgG. But you should also be thinking about other infectious causes of neuroretinitis, and that includes syphilis, for which the test is also an IgG, or you can do a treponemal test, either the fluorescent treponemal antibody test or some T test. We know that a treponemal test has a T in it, like FTA, fluorescent treponemal antibody, microhemagglutination for treponemal pallidum, or treponemal plasma agglutination. All of these are T, they are treponemal tests, followed by a non-treponemal test. The non-treponemal tests don't have a T in them. Those are the RPR, rapid plasma reagent, and the VDRL, the venereal disease research laboratory test. So you need both the treponemal test and the non-treponemal test, because once the treponemal test is positive, even with treatment, the treponemal test will stay positive. So if you have a positive FTA, even if you're treated with adequate dosing of penicillin, it just stays positive forever. However, the RPR and the VDRL reflect activity of disease. And so if the RPR is positive and the FTA are positive, then you have active disease and we have to treat it. If the RPR is positive but the treponemal test is negative, that's probably a false positive non-treponemal test, because the treponemal tests are more specific and sensitive. And if you have negative both, then you don't have syphilis. If you have a positive treponemal test but a negative non-treponemal test, FTA positive, RPR or VDRL negative, then they have to have proof on a piece of paper that they were treated with penicillin in the past, or you have to repeat the treponemal test or just treat them. In addition, you should be thinking about Lyme disease. And the testing strategy for Lyme disease is a two-step process. We have to do the ELISA, which is the screening. But even if it's positive, because the sensitivity and specificity of the test is not that great, we would do a confirmatory Western blot. And the CDC has very specific requirements on what bands they will accept and what number of bands they will accept, both for IgM and IgG. In ophthalmology, we're normally ordering the IgG because the IgM is only for the rash. And that looks like a bullseye or a target called erythema chronica migrans. But we hardly ever see the patient during the rash phase, so IgG is what we're looking for. Two-stage test, ELISA, if positive, Western blot. And then we have to think about tuberculosis. And tuberculosis does not have any immunoglobulin, because tuberculosis is not that kind of reaction. It's not an antibody-mediated hypersensitivity reaction. In fact, it's kind of delayed type. And therefore, we have to use an assessment, a quantitative assay of interferon, called an interferon gamma release assay. This interferon gamma release assay measures sensitized T cells' response to TB antigen. So if you've seen tuberculosis before, we can take your blood and see if those sensitized T cells will release interferon gamma in response to TB antigen. And those have trade names like quantiferon and TB spot and things like that. We'd also do a chest x-ray here. You should also think about the inflammatory causes of neuroretinitis, just like sarcoidosis. Other infectious agents can cause it, hepatitis, herpes family viruses, but really the main thing is Bartonella. And once you've got a positive, you should treat it with antibiotics. If it's bilateral, I would image that, because papilledema can mimic the appearance of disc edema with a star figure. If it's bilateral, you should also check the blood pressure and make sure that it is not malignant hypertension, which would require admission to the hospital. But most cases are infectious neuroretinitis, and most cases are Bartonella. Some of the cases are syphilis. Lyme and TB are rare. If no cause is found, idiopathic, and the idiopathic has an eponym, idiopathic stellate neuroretinitis. That is a diagnosis of exclusion.